Recording in progress.
මේකේ ස්ක්‍රීන් මේ ෂෙයා කරපු එක පේනවද?
ඔව් හරි.
Right. Slides move වෙනවා පේනවද?
පේනවා.
Okay. Good morning to you all. Today is the second day I'm joining with you regarding today topic is blood metabolism, mainly glucose and lipid metabolism. So today my objectives are briefly describe what are these glucose and lipids. Especially I highlighted on how we are investigating those substances in our laboratory day to day, especially with how patient preparations and what are the important criteria diagnosis and how we need to treat with the samples. So let's move on to the introduction. So it's glucose and lipids are mainly important metabolic products in our body, and as we are receiving blood, so blood is the main transport medium in our body. So all these lipids, glucose, proteins and everything transport through this medium, and these things are essential for our cellular energy production as well as the development. So once we take the blood and if we analyze those substances in our blood samples, it reflects the metabolic state of our body. So that means what happened inside our body easily reflected through these test results. So it will help to clinicians to screen for certain diseases and diagnose certain diseases like diabetes and dyslipidemias, mainly. Hello. Mainly those two things are non-communicable diseases, and the blood results will help to monitor the disease progression and to response or not. So first we look at the carbohydrate or ultimate product glucose. So carbohydrate partially digested started in our mouth by salivary amylase. Then it will goes to our stomach, but there is no digestion takes place inside our stomach. The rest of the digestion part of carbohydrate will happen inside our small intestine. So this is the diagram shows that what are the enzymes involved in this process. I think those things are very basic things, and you can easily go through with this diagram. So ultimate product from the carbohydrate is glucose. So when we talk about glucose, there are three pathways of blood glucose appearance, and there are many pathways of blood glucose utilization. So mainly blood glucose comes from our diet, directly from the diet, and so some part of glucose produced in our body through the glycogenolysis. So that means stored glycogen degraded into products and releasing glucose. Then the other thing is gluconeogenesis. So that means production of glucose other than the glycogen. So that means you can, in this process, there can be proteins or amino acids which will leads to produce blood glucose. So there are three pathways of formation of blood glucose, majority from diet. Other two processes are glycogenolysis and gluconeogenesis. Inside the cells, there's a glycolysis process from where this glucose is taken as a substrate to produce energy. Blood glucose when it is excess or in excess way. So blood glucose mainly used as I told you, glycolysis, oxidation process. Through this oxidation process, it generate what are the energy requirement in our body. The other thing is storage. So if your blood glucose is excess, it will store as a glycogen, the process called as glycogenesis. And part of this excess glucose will stored as a lipids. So the process is called as lipogenesis. So if you have additional glucose in your blood, it will end up with either glycogen or either lipids. So let's move on to the hormonal effect of this hormone involvement in this process. So there are many hormones like insulin, cortisol, and thyroxine, but majority of we talk about insulin and glucagon, which are secreted from pancreas, islets of Langerhans, and if your blood glucose levels goes up after taking meals or something, if your blood glucose levels goes up, and it will send your pancreas to produce insulin, and then insulin comes and asks increase the glucose uptake by cells or the, and the other, it will enhance the glycogenesis or the glycogen synthesis. So that's how your body responds with this insulin hormone once your blood glucose levels goes up. Imagine that if your blood glucose levels goes down, again it will send the pancreas to secrete glucagon, where you need more and more glucose. So at that time, this glucagon go and act on the liver cells and produce glucose from the stored glycogen, glycogenolysis, breakdown of stored glucose. If you have not enough glycogen levels in your blood body, the required amount of glucose will produce through the gluconeogenesis other than the glycogen substrate. So that is how mainly these two hormones are involving this glucose metabolism. But other hormones like growth hormone, epinephrine, cortisol, thyroxine, those hormones also affect some amount of this glucose metabolism. So with this glucose background, we highly consider on blood glucose measurement, because as MLTs, always we receive blood glucose samples for analysis in different names. And when you are analyzing the samples, sometimes you may receive plasma samples. Sometimes you have to do with glucometers. In glucometers, you have to use whole blood. So the sample types can be arterial blood, venous blood, or capillary blood. But you should know these things. When compared to the capillary blood and venous blood, there's a difference in values if you check at the same time. Because in whole blood, the plasma content, as in this diagram, in a whole blood drop, your plasma content is very much low. And the same time, if you separate the blood, the plasma content is very much high. So if you analyze the value, you should get 12 to 15% low value compared to your plasma values. So, and the other thing, that is the difference between capillary blood values and the venous blood value. Not only that, there's a difference between postprandial, after meals, because in our body, after digestion, glucose diffusion starts from arteries, capillaries to veins. So just after lunch or just after meals, after digestion, the high amount of glucose presence in arteries, and then it will end up with capillary beds, and then circulating back with the veins. So at that time, we are taking the venous blood samples. That venous blood samples, blood glucose are low. So those are the difference between having meal differences. So if you take samples of fasting samples, that means your digestion is already completed, absorption is already completed, and now your blood circulating. So in your circulating blood, the glucose is diffused into the tissues and going back to the circulatory system in the veins. So at that time, it will indicate the appropriate level of blood glucose in your body, right? So when you are using self-monitoring devices like glucometers, you should know these things when before. Sometimes some patients are there, they are comparing their values before going to giving the blood. They check their blood glucose value with the glucometer and come to you. So if those two what is the reason behind this difference? So not only that, there's a difference for a long period of time starts this process of glycolysis and utilize glucose. So that means your whole blood sample blood glucose levels goes down, as well as leukocytes also increase in the glycolysis. Not only that, if contaminated with bacterial, it will further degrade the blood glucose. So there should be a way of preventing these three processes. So that's why we are using preservatives or the additives with our blood collection tubes. So the best preservative combination for plasma glucose assay is sodium fluoride and potassium oxalate. So sodium fluoride mainly acts on an enzyme called enolase, which is in glycolysis pathway, and block that enzyme. So after that, that further glycolysis is not taking place. And also sodium fluoride has minor anticoagulant, or the sodium fluoride molecule can chelate calcium and preventing blood clot. So the other preservative substance, potassium oxalate, that is the main anticoagulant in the mixture, which is act as an anticoagulant. But most of the sugar tubes are receiving with this sodium fluoride only, because sodium fluoride can act as a glycolysis enzyme inhibitor as well as the anticoagulant at the same time. But the thing is, you can't use this sodium fluoride excessively. There should be a recommended ratio for using the sodium fluoride and potassium oxalate, 1:3. 1 part of sodium fluoride, 3 parts of potassium oxalate per 1 ml of blood. Because if you add excess amount of the sodium fluoride, mainly our glucose assays depends on glucose oxidase, peroxidase, and hexokinase method. So those are also enzyme which can affect by the sodium fluoride. So that's why we are recommended this ratio, 1:3 ratio for blood collection. And that is the main reason we need the blood collected up to correct volume. If you issue a blood sugar tube to the wards, there's a mark where you fill the blood. So that's why we ask them to maintain that level, because if you add blood up to that level, then only it will make of blood into the tube. There should be a excess amount of sodium fluoride in that sample, which will affect on your later enzyme assays. So therefore, sodium fluoride concentration should be limited to less than 5 milligram per 1 ml of blood. So after considering all these things, that manufacturers are design their blood sugar tubes to collect the appropriate volume of blood. So as a MLTs, we should concern of properly collected blood samples up to the level, because end up with another problem. So when we are handling specimens, especially blood glucose specimens, we need plasma with correct anticoagulant, and it's stable at room temperature for up to 3 days. But we are never keeping our blood samples for 3 days at room temperature. Then CSF specimens, it's better to centrifuge your sample if you are delaying analysis and place in a refrigerator or -20 to prevent the further glycolysis by bacterial contamination or likewise. Then mainly avoid the blood drawing from arm with IV infusion, which will dilute your blood. It's very non-fat. And as you can, once you receive the samples, as soon as possible, please separate the plasma to assay the sample. It should be redness and leukocytes free. So then you can ensure that you are collect a blood sample correctly. Then when you are mixing the blood samples, don't shake it vigorously, because the vigorous shaking will end up with hemolysis. Hemolysis has many effects on your sample analysis. I will discuss later. Then the other thing, when you are transforming blood into the blood from syringe to your blood collection tube, please remove the needles, because if you expel your sample through the needle, then it will enhance the hemolysis of your sample. And with all these collection procedures, there you can collect venous blood or the plasma samples or the whole blood for glucose estimation. But based on some testings like fasting blood sugar, random blood sugar, postprandial blood sugar, oral glucose tolerance test, glucose challenge test. Based on these test requirement, there may be difference. That means either patient preparation or sample collection or likewise. So let's move one by one. For the patient preparation of fasting glucose testing, you need 8 to 10 hours fasting, typically overnight. But during these 8 to 10 hours, there should be no calorie intake. So you can't take tea, coffee or anything during this 8 to 10 hours. And only you can permit clear water, plain water, to maintain the hydration, because if you are not taking even a cup of water, it will end up with the dehydration. So it's very difficult when you are going to withdraw the blood. So the patient should refrain from alcohol for 24 hours before testing and avoid strenuous exercises during 24 hours. So that means if you are planning to take blood samples on today, before 24 hours, you have to avoid your alcohol consumption and the strenuous exercises. And not only that, you have to maintain your normal carbohydrate diet for 3 days. And especially if you are in a current illness or the infection-like thing, please don't attend with this fasting glucose assay. It will change your metabolic process inside the body, and it will not reflect the accurate glucose levels in your body. And medication, it's a very controversial thing, because we can't ask patient to stop insulin or the other glucose controlling drugs, because that decision should be taken by a clinician or the medical officer. Not only these insulin and glucose controlling drugs, certain other medications like corticosteroids, diuretics, and beta blockers, you should notice them, but don't attempt to stop those medication unless prescribed by a medical officer. Then patient preparation for postprandial blood glucose testing, so shortened form PPBS. In PPBS, it's highly advisable to collect blood samples exactly 2 hours after major meal. So that major meal should be a carbohydrate meal, not the simple bun or tea or like thing. It should be a major meal. That's why it's preferably after lunch. So normally some patients are there, they come for fasting blood sugar testing, and the same day they are waiting for another 2 hours after having a meal and getting the PPBS. But it's not the correct way. If you are doing fasting blood sugar on that day, please don't engage with the PPBS assessment on the same day. You have to select another day. So during these 2 hours, you are not allowed to eating or drinking any beverages or any calorie within these two hours after having a meal, and avoid heavy physical activities, stress or walking during these 2 hours. So that means after having your major meal, you have to rest for 2 hours and give the blood. Medications that may interfere with glucose level should be avoided with the medical officer's advice, and you have to collect the blood into the same tube containing sodium chloride and potassium oxalate as an anticoagulant. The other important test is oral glucose tolerance test, OGTTs. So I select these 3 types of testing, especially in our laboratory. The first thing, oral glucose tolerance test. Earlier, we collect a large number of blood samples and urine samples, but nowadays it's only 2 samples. So first you have to explain the procedure to the patient and take the consent and ask the patient to consume a balanced diet for at least 3 days before the test. And on the day he's coming, he need to come after 8 hours of fasting. But you can change this 8 hours fasting based on the age of the person. If you need to fast for an infant like 4 months, you have to wait for 4 hours in between feeding. 6-month babies, you have to wait for 6 hours fasting, and 6 to 12 months, 8 hours fasting is recommended. Then advise the patient to be at rest and avoid smoking or strenuous exercise during this fasting period, and avoid medications that will affect on glucose level with the medical officer's instruction. And the other important thing is ask the patient to remain in the laboratory for at least 2 hours. So that means once you start the collecting samples, he need to be there at the exactly after 2 hours, because don't allow them to go here and there. And the other thing, you have to postpone the patient, postpone this testing, especially the patient in infection or acute illness, because it will change your metabolic process. That's why we ask them to avoid that period of time and do it another day. And if you have any endocrine disorders, hormone disorders, before coming to this OGTT testing, first you have to rule out the endocrine disorder, because as I told you earlier, there are many hormones involved in this glucose metabolism. So if there is any changes in these endocrine systems, it will affect on your results. So the glucose tolerance test, especially the preferred timing is morning time. And as a baseline, the first sample, you have to collect the fasting blood sugar, fasting blood sample into a anticoagulated tube, and then you can administer the glucose dose. So most of the time, dose it's a 1.75 grams of glucose per kilogram of body weight, but you can use maximum 75 gram for a person, and this 75 gram of D-glucose should be dissolved in 300 ml of water, small cup of water. If you need, you can add some flavoring, but ask the patient to consume this glucose dose within 5 to 10 minutes, because if you are dragging this glucose intake, it will change your results. And after that, you have to wait for another 1 hour or 2 hours to take the samples. That initially we are taking fasting blood sugar sample, after 1 hour sample, and after 2nd hour sample. But nowadays, current practice is fasting blood sugar sample and directly after 2 hour sample. So that means in OGTT testing, nowadays we are receiving only 2 fasting value 2 hours, you need to prepare your patient. So I'm not mentioning the random samples and blood sugar series like things. So those things you can go through with your notes. Then because fasting blood sugar, PPBS and OGTT are main type of glucose analysis you are receiving in your laboratory. So in my next slide, I will describe blood glucose estimation methods. There can be two methods, chemical methods and the enzymatic method. But chemical methods which are very outdated now, alkaline copper reduction, alkaline pericyanide, orthotoluidine method, we are not practicing with this method nowadays. The enzymatic methods are very much popular because of easiness to handle and interferences are less. So oxidase, GOD, POD, glucose oxidase and peroxidase method. The other one is hexokinase method. Let's look at ODPD method first. Here there's a coupled enzyme reaction. That means mainly two enzymes. Right. So get aggressive with me. I know that you are listening to these lectures while working. So if you can please mute your mics, then others will appreciate you, right? So the glucose oxidase method, the first reaction is this GOD, oxidase enzyme, act on your glucose substrate in the sample and converted into gluconic and hydrogen peroxide. As a second reaction, this hydrogen peroxide break down into water and free oxygen radicals by peroxidase method. Keep in mind, peroxidase always break down hydrogen peroxide into water molecules and the free oxygen radicals. There's a difference between these peroxidase and catalase. I will discuss later. Once these free radicals are formed in the presence of oxygen acceptor like 4-aminophenazone, you will get the pink color complex in the presence of phenol. So that pink color complex, you can measure this color intensity through spectrophotometrically at 510 nanometer. Don't think this is the same thing happen inside that plasma combined with the reagents and gives the pink color complex, and then through your automated system, it will measure your the color, display your the value. So this is the summarization of this process. Glucose converted into gluconic acid and hydrogen peroxide by GOD. Then hydrogen peroxide break down into water and radical O in the presence of peroxidase. And this free oxygen radical combined with 4-aminophenazone and the phenol to give red color complex at 37 pH7 reaction, which we can measure at 510 nanometer. So the other thing, hexokinase method, popular glucose assay. Again, hexokinase is an enzyme, coupled enzyme reaction. In the first reaction, this hexokinase catalyze glucose by phosphorylation of glucose into glucose 6-phosphate. So hexokinase stimulate the phosphorylation of glucose into glucose 6-phosphate as the first reaction. Then second reaction, this glucose 6-phosphate oxidized by T6PD, glucose 6-phosphodehydrogenase enzyme into 6-phosphogluconate. The same time, NAD plus in your system converted into NADH, where we can catch the increasing of NADH level at 340 nanometer. So it's 340 nanometer is not a visible range, right? So but in your spectrophotometers or the analyzers, they can measure this increasing of NADH levels at 340 nanometer range, which will proportionate to the amount of glucose in your sample, right? So you can use serum heparin or fluoride plasma to assess glucose level by if you take samples without any preservative, you have to separate the assay. So in our practice, we are using plasma tubes, so the sodium fluoride tubes. So there is no problem. You can separate the samples and analyze. There are differences in this oxidase, peroxidase, and hexokinase method. So oxidase, peroxidase is a less expensive method, but the thing is there are many interferences like ascorbic, hemolysis, and uric acid. In hexokinase, it's a highly specific and minimum interferences with excellent CV, excellent precision. So then the other thing in oxidase, peroxidase method, it's very much sensitive with the hematocrit or the PCV value if you are using point of care devices. If you are using glucometers for the analysis, it will affect on your PCV, patient's PCV values, hematocrit. And in hexokinase, it's a very traceable standard method. You can trace the references for this hexokinase method, and it's better with the automated system. So these are the interferences. I select these hemolysis as icteric and light. If the red cells are damaged, it will release the intracellular substances into the plasma, and this hydrogen peroxide comes from the first reaction. Then in glucose oxidase, the first reaction produce hydrogen peroxide. If your samples contains catalase or hemoglobin, this hydrogen peroxide totally degrade. So that means water and the oxygen molecule. So there won't be any in the samples for the next color development. So that leads to falsely low glucose results in oxidase peroxidase assay. The same time, ascorbic acid also the same thing. It's a high reducing agent, and it can destroy the hydrogen peroxide into molecular water and the oxygen. So there won't be any free radicals in the samples to react, and there won't be any color production. So that's why if the sample is contaminated with ascorbic acid, you will get low glucose reading, and the amount of interference depend on the amount of ascorbic acid levels in your blood. Then think about the icteric or the high bilirubin levels in your samples. The same way, it will affect with your peroxidase reaction, and this interference can be minimized by incorporating bilirubin oxidase into your reagents, or in the interference. Then thing is lipemia, especially lipemia. It will cause due to high triglyceride levels in your samples, and so once you are going to measure the color production, because of this high triglyceride levels, it will form the turbidity. So definitely you can use the sample blanking to remove this lipemic thing from the samples. And the other important thing is nowadays in automated analyzers, they talk about HIL index, hemolysis, icteric and lipemic. Most of the instruments are programmed with this HIL index. So that means automatically they will select the good samples based on certain indexes. So that means before analysis, you have to program your instruments with this amount of hemolysis identification, amount of icteric level identification, and amount of lipemic level identification. And based on those criteria, your automated analyzer will flag you. These numbers of samples are not good for the analysis because this is increasing hemolysis index. Likewise, there's a system in automated analyzers nowadays. If you are not have that facility, by looking at the samples, you can judge whether these are highly icteric samples and lipemic. Here I describe some tests. What are the tests that affect due to hemolysis, like potassium, LDH, AST, haptoglobin levels. And if you have high icteric samples, especially creatinine in Jaffe method, total protein levels, cholesterol levels can get affected. With high lipemic index, your electrolytes values get changed, and enzymes and glucose. So with this HIL index, you can ensure the accuracy and reliability of laboratory results, and it's easy to identify the rejection. What are the samples you have to reject without analyzing? So please consider these three things when you are receiving the samples and before analyzing the samples. The important thing of this glucose is it's directly related with the main non-communicable disease in our society, diabetes. So glucose is a main point to check the diagnosis of this diabetes, but let's move one by one. There can be a clinical and biochemical findings for this diagnosis of diabetes. There are many symptoms like polyuria, polydipsia, weaknesses, tiredness, and loss of weight. That those are the symptoms from the patient. And if you analyze urine sample, you can have urine sugars, ketone bodies, microalbuminuria, and UFR with many changes, deposits. And biochemical assays, fasting blood sugar, PPBS, glucose challenge test, OGTT, HbA1c. Not only that, if you are monitoring for a long period of time, there can be lipid parameter changes, serum insulin level changes, HbA1c changes like this. Further, you can use immunological findings. So time you can get diabetes due to autoantibodies. So that means certain antibodies are there. It will damage to your pancreas. So then you have to find out those autoantibodies. So those are the immunological findings related with this diabetes. So there are several types of diabetes. Type 1 diabetes, type 2. Type 1 is insulin dependent. Type 2 is non-insulin dependent. Then gestational diabetes develop through your pregnancy period. And there are other three types: latent autoimmune disease diabetes of adults, LADA, then maturity onset diabetes of young, and secondary diabetes. So initially you get up a different type of disease, but because of that disease, you can end up with diabetes. Those are the secondary types of diabetes. This is the simple comparison of this type 1 and type 2. The frequency, normally up to 5 to 10% of all reported cases are type 1, but type 2, more than 95% of report cases are type 2 diabetes. When we think about the onset, the appearance of this disease, type 1 suddenly appear, but type 2 gradually develop inside your body. And age, you can have type 1 diabetes in any age type. Most of the time, young age, you can end up with type 1 diabetes. Type 2 mostly appear in adult ages. If you think about the body status or the appearance of your body, so type 1 patients are always thin and sometimes with normal appearance. Type 2 diabetes patients are oftenly obese persons. Then ketoacidosis common in type 1 diabetes patient, very rare in type 2 diabetes patient. Autoantibodies, type 1 usually present with autoantibodies, but type 2 absent. If you think about the endogenous insulin levels, type 1 diabetes very much low or absent levels of insulin because type 1 is insulin dependent one. Type 2, endogenous insulin levels are normal. either increase or decrease. That means you have insulin, but the reaction is not there. When diabetes diagnosis criteria, so time to time there are many organizations like WHO, American Diabetic Association, they describe criteria for the diagnosis of this diabetes. The first criteria is the fasting plasma glucose level. It should be more than 126 or more than 7 millimoles per liter to diagnose as a diabetes. Then the second option is 2-hour plasma glucose levels in OGTT test. It should be 200 milligram per deciliter or more, 11.1 millimoles per liter to diagnose as a diabetes. Then the third criteria is random plasma glucose level, where you get more than 200 values or 11.1 millimoles per liter values with the symptoms. So when you are interpreting a RPS or the random plasma glucose value, there should be a patients with classic symptoms like hyperglycemia or hyperglycemic crisis. So when you are interpreting RBS, please consider with the symptoms of the patient. And the last criteria is the hemoglobin A1C, HbA1c. The level should be more than 6.5 or the 48 millimoles per liter. So these criteria you can use to diagnose the patient, as well as the monitoring of the progress of the patient. You can use these 4 criteria for that. So this is how the other way of classifying with fasting plasma glucose. If it is less than 100, it's normal. If it is 100 to 125, that means 100 to 125 milligram per deciliter, it's termed as pre-diabetes. If it is more than 126, termed as diabetes. When think about the OGTT test, I'm giving these values for second hour value. If your second hour value is less than 140, it's normal. If it is 140 to 199, termed as pre-diabetes. If it is more than 200 milligram per deciliter, termed as diabetes. Then HbA1c, if your value is less than 5.7, it's normal. 5.7 to 6.4, termed as pre-diabetes. And if your value is more than 6.5%, termed as diabetes. So what is this pre-diabetes? So now, up to now, we are talk about diabetes, and now there's a new term, pre-diabetes. So pre-diabetes, your blood sugar is higher than the normal blood, but you are unable to say straightforwardly it's diabetes. That means not yet diabetic range. Like if your blood sugar level is in between 100 to 125, fasting blood sugar, yes, you know that it's more than 100, it's a high value, but you can't term that patient as a diabetes because it's still in between 100 to 125. So at that time, you have to use another testing to confirm whether this patient is diabetes or pre-diabetes. So in this kind of patients, fasting blood sugar, that means if it is 100 to 125 values, we term as an impaired fasting glucose. But sometimes you are receiving these OGTT values 140 to 190. So at that time, you can term it as an impaired glucose tolerance. So this impaired term came with this in-between level, normal level and the diabetic level. So the pre-diabetes increases the risk of type 2 diabetes development, and especially the cardiovascular disease. So if you are in the pre-diabetic range, sometimes you may end up with type 2 diabetes. The other concern is cardiovascular disease. So you can maintain as a pre-diabetes range, but you can end up with either type 2 diabetes or cardiovascular disease. So that's why we highly concerned on this pre-diabetes. The thing is, these pre-diabetes patients are most of the time without any symptoms. So people don't know they are having pre-diabetes. And if you diagnose as a pre-diabetes, you have to screen the person every 1 or 2 years, because he or she can end up with type 2 diabetes or any other cardiovascular disease. So these are the ranges of results indicating pre-diabetes. In HbA1c, 5.7 to 6.4, fasting blood sugar 100 to 125, OGTT 2 hours blood 140 to 199. So if you are receiving a report like this, you should screen that person's in every 1 or 2 years to prevent the complications of type 2 diabetes and cardiovascular disease. So these are the health and care excellence. They are guidelines to pre-diabetic diagnosis. So as I mentioned you, they are giving what are the ranges for fasting plasma glucose, 2-hour OGTT, and HbA1c test values. So up to now, we discussed about plasma glucose, especially fasting and OGTT. So there's a term with HbA1c, the new thing, glycated hemoglobin. So that means you can measure your blood glucose controlling, or the last 3 months average plasma glucose concentration in your blood by assessing HbA1c, because this glycated hemoglobin is a product. If you have any excess amount of glucose in your blood, there's a tendency of this glucose to combine with hemoglobin molecule inside the red cell. So HbA1 is the normally in a person's, it's a 5 to 7%. But out of this HbA1, simple A1, HbA1A2, HbA1b, and HbA1c is the most predominant one. So that's why we are selecting this glycated hemoglobin HbA1c to assess the plasma glucose levels in your blood. So, and the other thing, these red cells have 120 days of lifespan. So each and every 120 days, that levels can be changed. So that's why if once you assess the HbA1c values, you can have a 3 months period of monitoring, so that without considering the blood sugar levels fluctuation or the fasting blood sugar levels report, you can go through with this HbA1c reports for the better understanding of how the patient's sugar control is happening. So HbA1c in diabetes, costly tool, and annually the testing of HbA1c is recommended for all individuals with diabetes, because if you have normal fasting blood sugar values with altered HbA1c levels, that means you are not in a compliance. So you are not taking treatments or taking diet controls in proper way. So you are not responding the drugs in a proper way, and that indicate high HbA1c indicate you are going to end up with certain cardiovascular diseases, diabetic nephropathy, kidney failures, neuropathy, nerves damages, and retinopathy, especially high visual disturbances. So high HbA1c indicating those complicated can arise due to diabetes. So monitoring of HbA1c type 1 diabetes patients will help you to assess long-term glycemic control, and it will guide you to change the drugs levels. So based on your HbA1c report, you can change your therapeutic levels. So drug levels. Then it will improve your clinical outcomes. So other than in fasting blood sugar, how much it is important, HbA1c double than the diet. So that means HbA1c can evaluate your 3 months control as well as the later on complications. So that's why HbA1c is a good glycemic control testing in our system. So there are numerous methods for HbA1c measurement. Broadly, can get into chromatography techniques, immunoassay. Most popular one is HPLC, high performance liquid chromatography test, and there are affinity chromatography, cation exchange chromatography, and isoelectric focusing. Though based on the assay principle, there's a change, but mainly the popular ones are HPLC methods and capillary electrophoresis method in our setup. So this is the HPLC instrument and the reporting pattern of this HbA1c. So you can you can observe this as a graph, and area under this peak indicate this black color one is the HbA1c levels in your blood. So the other diagrams, it indicates the electrophoretic system, capillary electrophoresis system. So already you know in normal serum protein electrophoresis, the protein particles are travel from cathode to anode, but in capillary electrophoresis, these samples are migrate, or the protein molecules are migrate from anode to cathode, the reverse way, not in the normal migration method. So advantages of doing this HbA1c is it's a good index of long-term sugar control over 120 days, because red cell have lifespan of 120 days. You can monitor your 120 days of glucose control. The test can be done at any time of the day without considering the calorie intake. So you don't want to fast the patient for HbA1c assay. And test will not influence by diet, exercise, or emotional stress. So there is no complicated patient preparation in this HbA1c testing. And it's a good marker for non-compliance of patients towards medication of diabetes. So patient can tell anything, but if you have your HbA1c value in your hand, it will give the total idea of your compliance with these medications. So these are the conditions where you can get falsely high HbA1c values and falsely low values. Falsely high values can come with uncontrolled diabetes, presence of some abnormal hemoglobins, iron deficiency anemia, hypertriglyceridemia, alcoholism. I don't think you have to memorize all these things, but if you receive some patients' reports, it's better to know these things. False low values can appear in chronic blood loss because your majority of red cells are lost. And recent blood transfusion, in your blood, you have two populations of red cells. One is from the donor and one is from your own. So that's why when you are collecting blood sample for HbA1c, please consider the recent blood transfusion of that patient. And chronic renal failure, most of the time, the HB is very low because erythropoietin, which is produced from the kidney, is important to produce this red cell. So in chronic renal failure patients, there can be low HbA1c value, and hemolytic anemia. Majority of red cells get lysed, so then you don't have enough red cells to assess in your blood. Then the type of specimen, EDTA whole blood is the specimen. Either you can use venipuncture, capillary, or capillary samples for HbA1c assay. There is no special patient preparation. You can take the blood at any time of the day, but the important thing is you have to avoid the hemolysis. If you damage your red cells while you are drawing the blood, it will affect on your test results. And sample stability depends on the assay method. So that means if you are using HPLC method, it will describe the storage conditions separately. If you are using capillary electrophoresis method, it will describe the separate way of storing. So generally it's stable for 1 week at +4, and you can store it at -70 for up to 1 year of time. And please consider the recent blood loss and blood transfusion when you are collecting blood for HbA1c assay. So this is the chart of HbA1c results, and the same times normally HbA1c expressed as in percentage value, but there's another way of unit, millimoles per moles, to express the HbA1c levels in your blood. Based on the HbA1c level, you can have the estimated average glucose levels in your blood. As an example, if your HbA1 is 6%, that your average blood glucose level is 126 milligram per deciliter. Likewise, there are many references to you can go through. Then the other important thing is fructosamine, which is not practiced in our system more popularly, but fructosamine is the combination of excess glucose with proteins. So serum fructosamine is formed by irreversible non-enzymatic glycosylation of serum proteins, predominantly albumin with glucose. So glycated hemoglobin is combination of glucose hemoglobin. Here fructosamine, it's not the fructose molecule, it's a glucose molecule combined with albumin, because in our body the predominant protein is albumin. So and the important thing is this albumin molecule have the 14 to 21 days of lifespan. But before that, if you analyze fructosamine, you can reflect the stage of glycemic control for. So within 2 to 3 weeks of time, you can have your glycemic control or the blood sugar control. Especially this fructosamine level is important in patients with diabetic end-stage renal disease. Patients who are having diabetic end-stage renal disease. So that means end-stage renal disease means that the amount of his or her renal function is very much low. So there won't be any production of red cells because of the lack of erythropoietin. So at that time, there should be a way of assessing the glucose monitoring, the compliance or the glycemic control of the patient. So therefore, you can use this fructosamine as a new marker to detect the, to assess the end-stage renal disease patients. And so the measuring methods are the same methods, HPLC method, affinity chromatography methods, and colorimetric procedures. But the only thing is, if you have conditions that affect the serum albumin production, or that means sometimes you can have a liver diseases. So liver is the organ producing this albumin. If you have liver disease, your albumin production is altered. Imagine that if you have any other renal disease that you are losing your albumin, so it will affect your total albumin level in your blood. So in those situations, your serum albumin levels are changed. So that will affect on your fructosamine assay. But generally, that there's a relation between this fructosamine and HbA1c like this. So you can see that if your HbA1c is 5, that means your fructosamine level is 212, but your glucose, normal blood glucose indicating 90. So each and every this testing, HbA1c, fasting blood sugar, as well as the fructomase, there's a correlation. So you can use this fructosamine as a diagnostic, not the diagnostic, to check the patient's prognosis of the disease. So for the fructosamine assay, serum or plasma can be used. Fasting is not necessary, and blood you can collect it into plain tubes. That is the difference between you have to use sodium fluoride tubes. HbA1c you have to use EDTA tubes. If you are using fructosamine, you have to use plain tubes. and it's stable for at 25 degrees for 3 days, at +4 for 7 to 14 days. So other important tests in diabetes are insulin levels, C-peptide levels, and detection of autoantibodies. So depending on your type of diabetes or the type of complication, you can go through with these insulin levels, C-peptide levels, and autoantibodies levels. So other than these diagnosis testing, the diabetes diagnosis criteria based on fasting blood sugar, 2-hour OGTT sample, random blood sugar, and HbA1c. Those 4 tests are the main diagnosis criteria for diabetes. So that is the end of diabetes and glucose metabolism. So I think with the time I need to move with the lipid analysis also. In lipid analysis, first, as blood glucose or the glucose metabolism in our blood, in lipid, there are 2 main pathways of transporting in our system. That is exogenous pathway and endogenous pathway. In exogenous pathway, it describes the transportation of dietary lipids up to the target organs. In endogenous pathway, it describes the transport of liver lipids. So lipids that are releasing from the liver and how it goes with the blood. In exogenous pathway, so dietary lipids are absorbed as chylomicrons, which are large particles, and it's a micelle. So that means this is the structure of lipoprotein, because lipids, it's not a water soluble thing. There should be a way of transporting in our blood. So lipoproteins molecules, it's a phospholipid, single layer of phospholipid molecules. So hydrophilic outer heads are there, and inside the core material you can have cholesterol, bound to fatty acids, free cholesterols, triglyceride, as well as the vitamin dissolving vitamins which are dissolved in lipids. Vitamin A, D, E, K substances are travel along with this lipoprotein molecule. And this lipoprotein molecule, there are proteins, special proteins embedded in this outer membrane, which are ApoA1, 2, and 3, ApoB48, ApoB100, ApoE, ApoC1, C2, and C3, ApoD. So these molecules are defined different lipoproteins. I will tell you later. And these protein molecules you can use in certain assessment methods in HDL and so in lipid transport, this is primarily transport dietary triglyceride from intestine to peripheral tissues. And VLDL is the main very low density lipoprotein. This is the initial molecule in endogenous pathway, which is released from the liver. And high VLDL levels correlate with cardiovascular risk. Then LDL, low density lipoprotein, it's a bad cholesterol, which is distributing cholesterol into peripheral tissues. And the important thing is these LDL, oxidized LDL molecules are increase the risk of atherosclerosis, blocking of coronary arteries. Then HDL, it's a good cholesterol or the healthy cholesterol, which is help to transport cholesterol reverse into your liver. So that means unwanted or oxidized molecules through the as a HDL molecule, it will transport to the liver again for the excretion from your body. So this is it's a diagram indicating the amount of triglyceride, cholesterol esters, phospholipids, and proteins, or the apoproteins, how much of these things are present in your lipoprotein. So main lipoproteins are chylomicrons, VLDL, LDL, and HDL. So the chylomicron is the molecule contain high amount of triglyceride. And in HDL is the molecule which contains high levels of proteins. So based on this composition, it can separate separate according to the density, high density, low density. It's a one kind of way of separating. And if you using electrophoresis method, you can use these protein levels to separate this cholesterol or the lipoprotein from your blood. So this is also a diagram indicating endogenous pathway, exogenous pathway, and reverse cholesterol pathway. So when we are moving to the method of analysis, so you can use chemical methods, enzymatic methods, immunochemical, that means antigen antibody related methods, and physical methods. As I described you by centrifugation and electrophoresis, those are the physical methods. So you can use different type of methods to assay these lipids. Chemical methods, I think all of you know about Lieberman-Burchard reaction, which is very old one, and nobody is practicing with this method now. So more popular method is enzymatic method. So this is the one method. I take it from a leaflet which you are using in your laboratory, cholesterol oxidase method. So as the end of this enzymatic process, you can read the color development, the intensity of color produced at the 500 nanometer wavelength. So that means each and every step, there should be a chromogen for aminophenazone, and there should be a reaction to produce hydrogen peroxide. Then only this hydrogen peroxide act with peroxidase to form a color complex. So these enzymatic methods can give inaccurate results in the presence of increased concentrations of bilirubin, ascorbic acid, and other substances, because as I told you earlier in glucose method, these substances are directly destroy this hydrogen peroxide production. Because if you need to get a correct color production, this hydrogen peroxide should be degraded by peroxidase, not the ascorbic acid or catalase or something in your sample. So this cholesterol oxidase method linear up to 600 to 700 milligram per deciliter. So that means you can use this method to detect up to 700 milligrams per deciliter level of lipids in your blood. So for the cholesterol sample, serum is the preferable one. Fasting is not essential. If you can do the fasting, it's okay, but you can assess the cholesterol only. I'm not talking the lipid profile. If you are requesting only for the serum cholesterol, you can go through with the non-fasting blood samples. So fasting has less effect on cholesterol levels because if you collect blood after meal, it will increase the levels of cholesterol less than 3%. So for the cholesterol assays, you need 2 to 3 ml of clotted blood or 2 ml of EDTA blood with the selection of your method. That means if you select a method, then you have to go through with the method and decide what are the types of specimens you need for the analysis. Again, you should avoid the hemolysis because it will affect on your cholesterol assay. You have to separate the samples immediately from the cells, because if you contact with the cells, there can be change of these cholesterol levels. And preferably, you have to analyze the cholesterol within the same day. If you are unable to analyze it on the same day, you can store the serum at +4 for 3 months. 4 days at +4, 3 months at -20, or more than that at -70 temperature. The thing is, highly lipemic samples, because of this lipemic, it will interfere with your absorbance results. So at that time, fasting is essential. So these are the methods for triglyceride assay. Not like cholesterol assay. In triglyceride assay, there's it's also a multiple enzymatic reaction, but you can have two different methods, method 1 and 2. In method 1, you can use the final the color production form at 540 nanometer. In method 2, it's not a visible color production, the changing of NAD into NADH, where you have to use 340 nanometer spectrophotometrically to detect the level. So in triglyceride method, either you can select color production method or 340 UV range of detection. Specimens, definitely for the triglyceride assay, serum is preferable sample, and 9 to 12 hours of fasting is essential. That's why when you are instructing a patient for lipid profile, it's a must. 9 to 12 hours fasting is must in triglyceride assays, in lipid profile. If you need to assess only the triglyceride, that's also you need 9 to 12 hours of fasting. Analyze the sample within 24 hours the sampling, because even at +4, spontaneous hydrolysis of triglyceride can occur. So that means if you want to analyze the triglyceride sample values, you have to analyze it immediately. You can't store at +4 even, because hydrolysis of triglyceride can take place. If the delaying, if the processing is delayed, you can separate the serum. Especially separate the serum means you have to separate the serum from cell pellet and store at +4. And like that, you can store the triglyceride sample -20 for several weeks and -70 for longer period of time. So the estimation of HDL here, that's the importance of apoprotein is coming. So these apoproteins A, B, and C are present in each and every lipoprotein molecule, but ApoB100 molecule containing in VLDL, IDL, and LDL. So you can use that ApoB100 molecule to separate those VLDL, IDLDL, and LDL other than the HDL. So you can use polyanion cations to precipitate this B100 molecule. You have to mix the reagent with serum and leave 10 to 15 minutes at room temperature for the reaction. And then only you have to use the appropriate centrifugation speed, 1500 G for 30 minutes. Because if you change this speed and the time of separation, it will not 100% separated. So that means if you reduce the centrifugation time or if you reduce the centrifugation speed, there won't be appropriate separation of that precipitated substance. So after precipitating, you can obtain the supernatant for HDL assay, because in supernatant, their only molecule is HDL. All the VLDL, IDL, and LDL molecule get substances like heparin, dextran sulfate, phosphotungstate, and polyethylene glycol to precipitate these lipoproteins other than HDL in your sample to assess the HDL level. So for the HDL sample, serum is the preferable one. You can use 9 to 12 hours of fasting, or non-samples also you can use. But most of the time in our country, HDL assay within the lipid profile analysis. So therefore, you have to ask the patient to 9 to 12 hours of fasting. Serum should be analyzed within 2 hours of sample collection because there's an enzyme called LCAT, lecithin cholesterol acyl transferase, which will increase the HDL in your sample. So immediately, once the clot is formed, you have to separate the samples and separate the serum from the cell pellet. Nowadays, it will achieve by using the gel tubes. So once the gel tubes centrifuge, the gel comes as a barrier between cell pellet and the serum. So there won't be any contact of this serum with the red cells. So there won't be any change of this HDL. So after performing the precipitation step, supernatant can separate and kept for +4 24 hours. So if you want to delay the analysis, anyway, you have to precipitate first the non-HDL things, VLDL, LDL things, and then only you can store the supername. So HDL is stable when stored at -20 for few months and -60. So LDL measurement or HDL, you can use two ways, either direct method or indirect method. So the direct method, you have to use EDTA samples. It's a somewhat complicated process, like you can use combination of ultracentrifugation and polyanion precipitation. Sometimes you can use the method for LDL. Selectively, you can precipitate the LDL and then assay for the rest of cholesterol, then you can see the difference in the in your samples. So for these LDL direct measurements, I think you can go for the commercial kit leaflets, because different suppliers are there. They are using different techniques. The common technique, we are still using certain laboratories, the Fried-Wald equation. So the red color highlighted one is the equation LDL equals to total cholesterol minus HDL minus triglyceride divided by 5. So if you use triglyceride values in milligram per deciliter, you have to divide this triglyceride by 5. If you are using other cholesterol values in millimoles per unit, you have to divide it by 2.2. So the common equation for this LDL indirect measurement method is the Fried-Wald equation, which is highlighted in red color. The thing is, you can apply this equation in certain conditions. There were several conditions are there. It should not be used in specimens that has more than 400 milligram per deciliter triglyceride values. So that means if you receive the sample and you analyze for the triglyceride and it indicates more than 400 milligram per deciliter. So at that time, you can't apply this equation to calculate LDL. So that means before applying the equation, you have to check whether the triglyceride level is more than 400 or less than 400. And you can't use the equation for non-fasting specimen because of this triglyceride effect. Because non-fasting means you can have the circulating chylomicrons. Because if your blood containing circulating chylomicrons, chylomicron is the molecule contain large amount of triglyceride. So that's why it's affect. So for the non-fasting samples, you can't apply this equation to calculate LDL. And the other thing is, you should not be used this equation for patients with type 3 hyperlipoproteinemia patients. And finally, these are the national cholesterol guidelines, NCEP guidelines. For the LDL, total cholesterol LDL reference ranges. So typically, in a lipid profile report, there are 4 parameters: total cholesterol, triglyceride, HDL, and LDL. But other than these main parameters, you can have certain indices to assess the cardiovascular disease risk. So regarding patient preparation for the lipid profile, ask them to please don't change the dietary habits for at least 3 weeks. Refrain from drinking alcohol for 3 days, because these triglyceride levels are increased in alcohol consumption, and especially avoid smoking and strenuous exercise during fasting period. And because smoking, it will affect on your HDL levels. 9 to 12 hours of overnight fasting is essential, and you are allowed only for plain water to prevent the daytime. Blood collection, patient should be seated for 10 to 15 minutes before taking blood, and check the patient's details on level of protein bound substances. So exercises 15 minutes before blood collection can change the approximately 6% of the cholesterol levels. So recommended to avoid strenuous exercise 2 to 3 hours before blood drawing. Then posture and cholesterol levels, there can be changes in posture. That means sitting or lying down in the bed rest patient or a sitting patient. Cholesterol levels may decrease 6% after sitting or lying down for 10 to 15 minutes. And positional changes are sometimes significantly influenced with these cholesterol results. Gender difference, especially women's, generally have low cholesterol levels than men's, except during childhood and after the early 50s because of the hormonal changes because of the menopause. Then application of tourniquet, the prolonged use of venous occlusion increases the cholesterol level. If you apply tourniquet for 10 minutes, you can change. It will change your cholesterol levels by 10 to 15% increasing. If you apply 2 minutes of occlusion, cholesterol may change by 2 to 5%. If you use up to 1 minute, is not associated with significant change. So that means it's better to avoid the application of tourniquet. But if you are unable to do without tourniquet, it should be less than 1 minute of time. Then hormonal influences, plasma cholesterol and triglyceride are highest at mid-menstruation cycle, corresponding to peak estrogen secretion. So when you are collecting bloods and interpreting the results, you should concern these things. Then smoking, HDL cholesterol is significantly low in smokers than in non-smokers. Lipid levels are elevated in cholesterol, it will elevated by 3%, triglyceride, it will elevated by 9.1%, LDL by 1.7. So anyway, for the lipid profile patient preparation, smoking, alcohol, and strenuous exercise are banned, should banned. Alcohol intake, it will increase serum triglyceride by more than 20 milligrams per deciliter. So when you are handling the samples, you have to allow some time for the clotting mechanism. At least it should be 30 minutes. And centrifugation speed and time should be appropriate. Then other than that, you will end up with some clot materials inside the serum and some cells in the serum. Hemolysis during collection will affect directly on chemical assay. Lipomimetic method, most of the time, mostly hemolyzed sample will affect significantly. So minor or the small amount of hemolysis is not too much interfere with the assay. Lipemia can interfere with triglyceride measurements due to in the sample. So other than these 4 parameters, cholesterol, triglyceride, LDL and HDL in lipid profile, there are some parameters derived from basic measurements like total cholesterol to HDL ratio, VLDL concentration, non-HDL concentration. So these indices are helpful to assess the cardiovascular risk. So other than these lipid profile parameters, the estimation of protein levels in lipoprotein molecules like ApoA1 to ApoB ratios and lipoprotein little a. So those are the which you can use to assess this cardiovascular risk compared to the lipid profile parameters, because these markers recommended authorization bodies.
Recording in progress.
End up with dyslipidemias. So dyslipidemias are generally defined by the clinical characteristics of patients and the results of laboratory tests. So mainly dyslipidemias categorized based on our laboratory results as well as the clinical symptoms. The important things are in this lipidemia, hyperlipidemia, that means increased levels of lipids. In this hyperlipidemia, there are two types: familial, that means genetic origin. The other one is acquired due to another underlying disease. You are acquiring this hyperlipidemia throughout of your lifetime. So I think that much of disease related with the lipid is enough, because hyperlipidemia is a very large area, and I think that it won't be helpful in much of this refreshment program. So any questions?
Madam.
So if you don't have any questions, I have two questions for you.
Madam, එක ප්‍රශ්නයක් තියෙනවා.
Right. So
Hello?
as up to my knowledge, this kind of questions will help you to refresh your knowledge. So writing short notes on patient preparations of lipid profile, patient preparation of OGTT, and what are the laboratory diagnosis?
Hello?
Diabetes. Yes.
Madam, එක ප්‍රශ්නයක් තියෙනවා.
Oh.
අර මේ glucose tolerance test එකේදී අර අවස්ථා තුනකදී blood ගන්නවනේ patient ගේ එහෙනවද?
චුට්ටක් හයියෙන් කියන්න පුළුවන් නැත්නම් මට ටෙක්ස්ට් මේකේ chat box එකට දාන්න පුළුවන්ද?
නෑ මම ප්‍රශ්නේ කියන්න. එතකොට ඒ අවස්ථා තුනේදී urine sugar බලන්න ඕනේ නේද?
OGTT test එකේ
ඔව්. අර blood ගන්නවනේ අවස්ථා තුනකදී fasting ඊට පස්සේ පැයකින් ආයෙ තව පැයකින් එතකොට urine sugar බලනවා නේද? ඒ අවස්ථා
මේ recently කියන්නේ දැන් අපේ දැන් තියෙන diagnosis criteria වල අපි urine sugar estimate කරන ගැන කියන්නෙම නැහැ. දැන් ඉස්සර තමයි මම හිතන්නේ OGTT අපි ඉගෙන ගන්න කාලෙත් fasting half an hour 1 hour එහෙම 6 samples ගත්තා. 6 blood samples and 6 urine samples, but it will ඒක දැන් පාවිච්චි වෙන්නෙම නැහැ. ඊට පස්සේ පාවිච්චි කරේ fasting එකයි first hour එකයි second hour එකයි. ඇත්තටම ඒකත් patient ගෙන් 3 times blood ගන්න එක it's not ethic කියන එක අනුව තමයි දැන් diagnosis criteria එක ඇත්තටම අපි බැලෙන්නේ fasting එකයි after 2 hours. ඒ values දෙක base කරගෙන තමයි OGTT එකේ diagnosis criteria වලට යන්නේ. අර අතරමැද ගත්ත blood sample වත් urine samples වත් දැන් කතා කරන්නේ නැහැ.
මැඩම් තව ප්‍රශ්නයක් තියෙනවා. දැන් ප්ලාස්මා වලින් කොලෙස්ටරෝල් ලිපිඩ් ප්‍රොෆයිල් බලනකොට ඒක සීරම් එකේ යගේට වඩා අඩු වෙනව නේද? ලෝ වැලියුස් එනවා නේද ප්ලාස්මා වලින් බලනකොට?
ඔව්. ඒක ඇත්තටම ඩිපෙන්ඩ් වෙන්නේ කොලෙස්ටරෝල් වලට ඔයා ගන්න සීරම්ද ප්ලාස්මාද කියන එක ඩිපෙන්ඩ් වෙන්නේ ඔයා සිලෙක්ට් කරන මෙතඩ් එක අනුව. because දැන් අපි සිලෙක්ට් කරන රියේජන්ට් එක හරි මෙතඩ් එක හරි ඒගොල්ලෝ එස්ටැබ්ලිෂ් කරලා දෙනවා අපිට මොන සාම්පල් එකද ඕනේ කියලා. හැබැයි preferable සීරම් සාම්පල් එක මොකද අපි ඒකෙදි ඔක්කොම blood proteins අයින් කරලා clear serum එකක් එන්නේ, but plasma එකේ changes තියෙනවා. හැබැයි එයාලා හදලා තියෙන method එක plasma වලිනුත් කරන්න පුළුවන් කියලා කියනවනම් we can go for the plasma samples, but as a general for the cholesterol assay serum is the best sample.
serum තව ප්‍රශ්නයක් තියෙනවා මැඩම් අර දැන් ග්ලූකෝස් ඩයබටික් 1 නෑ අර 1 2 කියලා කිව්වේ මේ ඩයබටික් මෙලිටස් එකයි ඉන්සිපිඩස් එකයි දෙන්නේ.
ඔව් type 1 type 2 කියලා අපි ඒ කියන්නේ type 1 කියන්නේ insulin dependent එක, type 2 කියන්නේ non insulin dependent.
ඒ කියන්නේ අර මෙලයිටස් ඉන්සිපිඩස් කියන ඒ දෙකමද
ඇදුන්නේ. ඒ අර අපේ පරණ තිබිච්ච classification එකම තමයි. දැන් type 1 එකයි type 2 එකයි අරෙන්න gestational diabetes කියලා එකක් තියෙනවා. ඒ කියන්නේ pregnancy period එකේදී develop වෙන එක. අනික් එක ඔය auto antibodies නිසා එන අර latent ඒ දෙක ඒ other types ටික අලුතෙන් ඇවිල්ලා තියෙනවා. ඒ කියන්නේ දැන් ඔයගොල්ලෝ if you are searching for diabetic types. දැන් diabetic type search කරොත් අපිට type 1 එකයි type 2 එකක් විතරයි නෙමෙයි එන්නේ. අනික් types උත් දැන් පාවිච්චි වෙනවා. ඒ කියන්නේ auto antibodies check කරන එක අනුව ඒ තියෙන antibodies type එක අනුව diabetic තව classify කරනවා.
classify.
ඔව්.
හරි, thank you.
Any other? Right. So if you don't have any other questions, I think you can practice for the. Hello. Right. So you can. You can go through with these questions also, like short notes like thing. Okay. Slideshow again. Right. මං slide sharing එක නැවැත්තුවා. මට ඇත්තටම කියන්න ඕනුනේ the last two slides that questions. Then one thing is you have to practice with the write short notes like thing, and the other one is the biochemical investigations that should be done in a patient who has diabetes for few years. I will share these things with PDF. So basically with this lipid metabolism and the glucose metabolism, that kind of questions you need to answer. That means that and assay methods and those things are included in my presentation to fresh up your knowledge. But as class 1 in Maltese, you should engage with this patient preparation, day-to-day troubles like thing. You have to correlate with this blood glucose and lipids into that level, not the analysis level, right? Anything else to clarify?
Rama, one question in the chat box.
මට ඇහුන්නේ චුට්ටක් ආයි කියන්නකෝ.
Chat box එක බලන්න.
Chat box එක. Wait. Yes. There's a question, differences between glucose challenge test and OGTT. Yes. In OGTT, you are taking fasting blood sugar and then you are administrating a glucose dose, and then you are taking blood samples exactly after 2 hours. But in glucose test, most of the time this test done on pregnant mothers. As described by the physician, you need to give certain dose of glucose and wait for 2 hours and collect the blood, not the fasting like in OGTT. There's a difference between glucose challenge and the OGTT. හරිනේ the chat box එකේ ප්‍රශ්නෙට. Okay. Any other questions? තව කවුරු හරි කතා කරනවා මට. Right. Thank you very much. Even with your busy schedule time, I know it's a very difficult time to listen this kind of lectures. Yes, madam, explain why this anhydrous glucose is used for GTT. Because that D-glucose, it's very much easy to absorb and distribute in your blood easily. D-glucose is the D-glucose glucose especially requesting to because it's absorbance dietary glucose or something, it's very rapidly absorbed and rapidly appear in your blood. So that's why, because once we administrate the glucose dose, within 2 hours we need to know what will happen to the glucose. So if it is delay in absorbing and delay in appearing that, there won't be any point of using that kind of glucose. That's why we are using D-glucose.
Thank you, madam.
Okay, welcome. Anything else or? So I will upload this PDF. Contact anytime. Thank you very much for giving much for kind listening. Thank you very much.
Question in the chat box.
There's another question. Wait. Explain about ketoacidosis and gestational diabetes. Actually, ketoacidosis means in diabetic, you have in your blood, you have enough amount of glucose. But the thing is that glucose, it's unable to taken up by your normal body cells and utilize. So that means inside the cell environment, your body sense that you don't have enough glucose. So at that time, your cell starts to produce energy. So for that purpose, inside your cells, that energy production mainly targeted on lipids. So as a lipid oxidation, it's end up with keto acids like acetones, acetoacetates, and beta hydroxybutyrate things. So that's how ketoacidosis is appear. Your body have enough amount of glucose, which is unable to utilize by the cells, and that lack of glucose inside the cells, which sends the production of energy other than the glucose substrate. So other than the glucose substrate, it means the main substances you are using is lipids. So from that lipids, it's end up with ketone bodies. So that term condition termed as ketoacidosis. And gestational diabetes, I think that ketoacidosis answer is enough. Gestational diabetes is diabetics developed during the pregnant period. So during this pregnancy period, there can be many changes in your hormones and everything. So that, and the requirement of blood glucose is much high because of the fetus. So if you and because of some patients' genetic patterns, they have chance to get diabetes, but because of this gestational period, it will come out. And normally in gestational period, you have additional amount of blood glucose, but after the delivery, still you have developed that blood glucose, high blood glucose level, you will termed as diabetes developed due to gestation. ඒ කියන්නේ pregnancy period එකේදී develop වෙච්ච diabetic එක. ඒක සමහරක් විට ඒ blood glucose requirement එක වැඩි නිසා සහ hormonal changes නිසා වෙන්නත් පුළුවන්. එහෙම නැත්නම් ඔයාගේ ඇඟේ තිබිච්ච genetic reason එකක්. ඒ කියන්නේ ඔයාට chance එකක් තියෙනවා diabetic වෙන්න. but මේ pregnancy එක නිසා ඒක ඉක්මනට එළියට එන්න පුළුවන්. ඒකයි pregnancy period එකේදී every 28 after 28 of weeks you have to check for this gestational diabetes. හැම අම්මා කෙනෙක්ම මම හිතන්නේ ස්ක්‍රීන් කරනවා OGTT එක කරලා. මොකද 28 weeks වලට පස්සේ මේ gestational diabetes develop වීමේ හැකියාවක් තියෙනවා කියලා. සමහරුන්ට ඒ පීරියඩ් එකේ තියෙන ඩයබටික් එක ඩිලිවරි එකට පස්සේ නැතුව යනවා. සමහරුන්ට ඩිලිවරි එකෙන් පස්සෙත් ඒක පර්සිස්ට් වෙනවා. හරි නේද? Okay, thank you very much. I will share the presentation. Thank you very much for listening.
Thank you, Shama Pereira, our senior tutor at MRI. Thank you for your valuable support for conduct our online professional training and also our friend. Right? Thank you.
Thank you, Mr. Bogada. Thank you.